Bismillahirrahmanirrahim. I'm Dr. Humza Sajjad, and today we are going to start with the pediatric lecture for step 2 CK. So we'll be starting with the general principles. So they are like kind of notes, but I hope that all of that will make sense eventually we proceed in these sessions. So starting off, here is a small tip that liver edge is more than 3.5 centimeter in the neonates. No, if the liver edge is felt more than 3.5 centimeter in the neonates, that is hepatomegaly, like 3.5 centimeter below the rib cage. Pediatrics. So routine screening. Autism screening is performed at the age of 18 months and 2 years. Okay. Depression screening starts at age 12 years and then it is repeated annually. Visual acuity screening is routinely done at the age of 4 years. Now, routine of adolescent screening is also labeled over here. So for the mental health, it is validated depression questionnaire. For sexual health, confidential discussion about the sexual activity, gonorrhea and chlamydia testing if they're sexually active, and HIV testing once at the age of less than 18. Substance use, confidential discussion about the exposure, use and abuse, dyslipidemia, lipid panel once between the age of 17 and 21. What is that about? 9 to 11. I think that is something that we do in the children maybe, but lipid panel once between the age of 17 and 21 is done in the adults. And for the safety, inquire them about bullying and inquiring about the seat belt and helmet use. So these are for the adolescent children, like they're not adults, like they are the children who are adolescents. Yeah, and annually unless otherwise indicated. So the mnemonic for that is M3S and then we have D. So MS3D. HPV vaccine, I'm sorry, human papilloma virus vaccine. Age 15 or more than 15, 3 doses of HPV vaccine. If age is less than 15, then we give 2 doses of HPV vaccine 6 months apart. The difference is between the age of less than 16, the less than 15, the immune system is weak and leads to increased antibody production. Okay. If the immune system is weak, so how does it lead to increased antibody production? Immune system is weak and it tends to produce more antibodies to make it stronger. I don't know, it just does not make sense. The thing is that if the child is less than 15, so you give only 2 doses of HPV. If the child is more than 15, then we can give 3 doses. Toilet training. Most children begin toilet training at the age of 2 to 4 years. Boys complete training later than the girls. Bedwetting is normal before the age of 5. Okay, so here is a uric acid crystals in the diaper, which can be seen in a lot of conditions. I will see them later on, but pink stains or brick dust in the neonatal diaper represent the uric acid crystals. Uric acid excretion is high at birth and decreases until the adolescence. Next, we have isolated speech delay. It is characterized by a problem with the following: articulation, like mispronunciation, fluency, like stuttering, and vocal quality, for example, abnormal volume or pitch. Speech should be 100% intelligible by the age of 4. The first step in the evaluation of all the patient with a speech or language disorder is a hearing test, because in most of the scenarios, the children are not having a problem with us with the speech. They can't listen to anything. That is why they can't articulate. So firstly, we perform the hearing test. If the child can hear normally, then we proceed with the hearing with the speech tests. Intraosseous cannulation. It is carried out in the emergency fluid resuscitation when the peripheral intravenous access cannot be obtained. It is easy to carry out and takes less time. The most common site for the intraosseous cannulation is proximal tibia. Contraindications include infections like cellulitis over the access site, fracture, previous intraosseous attempts in the chosen extremity, and bone fragility like in the children with osteogenesis imperfecta. Arterial line placement. It is placed for continuous BP monitoring, drawing laboratory studies. They should not be used for fluid resuscitation. In fact, the arterial line for other purposes should be placed after the patient has been resuscitated because it takes time and great skills. Infants' weight and height in first year. So weight doubles by 4 months, triples by 1 year. Neonates normally lose up to 7% of the birth weight in the first 5 days of life. Neonates regain the birth weight by age 0 to 14 days. Height increases by 50% by 1 year. So the weight doubles by 4 months and triples by 1 year. And you must remember the point that initially there is a 7% reduction in the birth weight in the first 5 days, and by 10 to 14 days the birth weight is regained, which then doubles by 4 months and triples by 1 year. Height is increased by 50% by 1 year. Head circumference, it is important marker for the growth and is routinely measured from birth to age 2 to 3 because brain growth is greatest during this period. Macrocephaly is considered when the head circumference is more than 97th percentile. Being benign macrocephaly is considered in the following cases, like in the cases of normal development, no syndromic features, no sign of increased intracranial pressure, and no signs of infection. Microcephaly is considered when the head circumference is less than 3 percentiles. So these are percentiles. So if the child is lying somewhere like over here, like there, and this is 51 centimeters, somewhat, or 50 centimeter, so that is considered abnormal. And then we have this is for the yeah, so if it is less than 3, so it is macrocephaly. If it is more than 97, then that is the area of macrocephaly, right? Why all of that is covered in macrocephaly, I don't know, but macrocephaly is like more than 97th percentile. Okay. And following, children should remain in rear facing car seat. Now we are talking about motor vehicle restraints. So about that, children should remain in rear facing car seats as long as the transition to a forward facing car seat only once they surpass the height or weight limit of their specific car seat. As it is determined by the manufacturer, there is no absolute height, weight, or age that determines the transition. So this is rear facing car seat, like it is rear facing, like it's a seat which is facing backwards. So children must remain in that seat until they attain a height or weight for specific car seat. Okay, so follow the manufacturer, then change the positions. Now age range is recommended safety device for 0 to 4 years, like it is in the years, right? 2 to 8, okay, so these are years. For 0 to 4 years we have to give the rear facing car seat, then forward facing car seat but elevated for children 2 to 8 years of age, booster seat for the children 5 to 12 years of age, and for 9 to adults we can give them seat belts and proper adult seats. Or earlier, if the children outgrows weight or height limitation on safety device, all children less than 13 should sit in the back passenger row. So children who are less than 13, they should not be allowed to sit on the front row. They should be sit on the back or passenger row. Seat belt positioning. Proper position, and then there is an improper position. So proper position is shoulder belt lies across the mid chest and clavicle. The lap belt lies across the hip and upper thighs. Knees bend over the edge of the seat. Improper is that shoulder belt rests on the neck. That's the wrong thing. It must rest on the mid chest and clavicle. Lap belt resides up on the abdomen. It must not happen because if any accident occurs, it can cause pancreatic injury or blunt abdominal trauma. And then knee don't reach the edge of the seat. That is also a wrong thing. So any child who is less than 13 years of age or does not meet these criteria should not be allowed to sit on the front seat. Then injury protection in the children. So there are different sort of injuries in different environments that the child can face. So injury prevention in the children in the water, never leave the child unattended around the water. Fence all 4 sides of pool and install self-locking, self-latching gate. Use the life jackets. Teach the child to swim. In the fire, install the smoke detectors on every level of the home. Test the smoke detectors and change battery regularly. For gun, if present, store gun unloaded and locked. Store the ammunition separately from the guns. Home, lock the medications and toxic household products out of reach. Remove the dangling cords and cover the power outlets. Install the safety gates on the stairs. Set the water heater to maximum temperature of 49 degrees Celsius, that is 120 degrees Fahrenheit. Mount the furniture and TV to wall. Avoid choking hazards, for example, whole grape, raw vegetable, and small objects. Then, what is the concept of strength training in children? Definition: resistance training. Exercise with free weights and weight machines. Use resistance to increase the ability to exert force. Benefits: increase the muscle strength and joint stability. Increase endurance and coordination. Increase the muscle mass if pubertal and post-pubertal. Pre-participation assessment. Cardiac and musculoskeletal examination, assessment of patient maturity, for example, ability to follow the directions, and typically we start at age more than 8. Safety guidelines, proper supervision and equipments, avoid excessive load. Contraindications, hypertrophic obstructive cardiomyopathy, pulmonary hypertension, and uncontrolled hypertension. Pediatrics, infant nutrition points. Breast milk fortified with the infant formula may be used in the following infants. Uh, like when do we need fortification in the infants? Infant is basically, yeah, infant is the child from 1 month to 1 year. The neonate is from the birth to birth till 28 days. Okay, so if the child has failed, if there is failure to thrive, and if it is a preterm infant, then we use the breast milk fortified with the infant formula. Formula supplementation can be considered in the infants who have lost more than 7% birth weight. We know that the children lose about 7% of the birth weight by the 5th day. But if they're losing more than that, then we can use formula supplementation despite optimization of breastfeeding. Never give plain water to infant aged less than 6 months because they have immature kidneys and that will lead to dilution of blood. Okay. Down syndrome. Patients with the Down syndrome often have low birth weight, that is less than 2.5 kgs. Hypotonia is a prominent feature which presents with poor feeding and weak suck and protruding tongue. Differentials include Fragile X syndrome, which can present with hypotonia in infancy but do not have low birth weight. So, difference between the Down syndrome and Fragile X syndrome, because both of them have abnormal bases. So, the problem, and both of them can also have hypotonia. The differentiating point is that the child who is having Down syndrome will have a low birth weight, while those of Fragile X syndrome will not have a low birth weight. Lesch-Nyhan syndrome. It is HGPRT deficiency. Presentation, early infancy, there will be delayed milestones and hypotonia. In early childhood by the age 3, extrapyramidal symptoms of dystonia and chorea will be visible. Pyramidal symptoms of spasticity and hyperreflexia will be seen. Self-mutilation, which means that the child will be picking his own skin. There will be excoriations on the body, or there will be cuts maybe on the body, and intellectual disability. Why do they do self-mutilation? Because the uric acid crystals will start depositing under the skin and they are very itchy. So while doing that itching, they cause self-mutilation. Untreated late disease can lead to gouty arthritis and obstructive neuropathy. So you have to remember this pattern. Like in early infancy, there will be delayed milestones and hypotonia. For early childhood, extrapyramidal symptoms of dystonia, chorea will be seen. Pardon me. Extrapyramidal symptoms of spasticity and hyperreflexia, self-mutilation, and intellectual disability will be evident. And then in the adults, if the child lives long enough, so there may be gouty arthritis as well. So yeah. Primitive reflexes end period. Most primitive reflexes end by the age of 6 months. Babinski sign persists up to 2 years but disappears by the A. But it can persist up to 2 years, but it disappears as early as 12 months. So it is a late. It's a reflex that persists for longer time. Otherwise, most of the primitive reflexes they are vanished by the age of 6 months. Then the next point is that the Niemann-Pick disease. So there are 3 types of Niemann-Pick disease. Type A is most severe, and the child will die by age of 3 years. It is basically a lipid storage disease, and type B and C are mild. Type A and B are due to sphingomyelinase deficiency. Autosomal recessive. Okay. Onset is 2 to 6 months of age. Findings include cherry red macula, hepatosplenomegaly, hypo or areflexia, and loss of motor milestones. There is a similar condition. I'm forgetting the name. That's Tay-Sachs disease. Yeah, Tay-Sachs disease is a very similar condition to Niemann-Pick disease. So we'll see that later on. So, but for the Niemann-Pick disease, you must remember that it is type A and B are caused by the sphingomyelinase deficiency, and findings will be cherry red macula, hepatosplenomegaly, hypo or areflexia, and loss of motor milestones. Niemann-Pick disease versus Tay-Sachs disease. The diagnosis is the pathology basically is sphingomyelinase deficiency in Niemann-Pick, while beta-hexosaminidase A deficiency in Tay-Sachs disease. Okay, epidemiology. Both of them are autosomal recessive in inheritance, and they are common in Ashkenazi Jew heritage. Onset is age of 2 to 6 months, and the clinical features include for the Niemann-Pick disease, we have loss of motor milestones, hypotonia, feeding difficulties, cherry red macula, hepatosplenomegaly, and areflexia. Similar manifestations are also seen in the Tay-Sachs disease, like there will be loss of motor milestones, hypotonia, feeding difficulties, cherry red macula, hyperreflexia. The problem is that in the Niemann-Pick disease, we find areflexia. While in the Tay-Sachs disease, there is hyperreflexia, and the second difference is that hepatosplenomegaly is present only in the Niemann-Pick disease, while the Tay-Sachs disease does not have that. And cherry red macula is present in both of them. Storage diseases. Tay-Sachs disease is hexosaminidase A deficiency, beta hexosaminidase A, right? Same as Niemann-Pick disease, except no hepatosplenomegaly, and there will be hyperreflexia in place of areflexia. Crab disease, it is a galactocerebrosidase deficiency. The clinical picture is same as Niemann-Pick disease without cherry red macula and hepatosplenomegaly. Then Gaucher disease, it is a glucocerebrosidase deficiency. It presents with anemia, thrombocytopenia, and hepatosplenomegaly. All bone findings, uh, all the bone findings and tissue paper, actually, they are crumbled tissue paper macrophages. Like the macrophages cytoplasm is appears as a crumbled tissue paper. I think they're trying to mention that. Then Hurler syndrome, lysosomal hydrolase deficiency, inguinal or umbilical hernias will be present, corneal clouding, and coarse facial features. Okay. Then we have galactosemia. So what is galactosemia? Galactosemia is basically excess. It is a condition in which the galactose cannot be metabolized. So etiology is galt deficiency. It is autosomal recessive. Actually, right now we are in the domain of biochemical biochemistry, and we are trying to get our hands on the genetic disorders. So most of the genetic disorders are autosomal recessive, right? If they are autosomal dominant disorders are very rare to find. So whenever you find one, just keep that in mind, that that particular disorder is autosomal dominant. Otherwise, most of the disorders are recessive in nature, and this is in the domains of autosomal disorders. Then X-linked disorders are a separate class. So etiology is autosomal recessive. Lactose accumulation after after lactose and galactose ingestion, and that's a horrible thing because the children who have them, all the children have to feed on the lactose and galactose rich breast milk in the initial part of their life. So there will be galactose accumulation after the ingestion of these things. The clinical findings is jaundice and hepatomegaly, vomiting and poor feeding and failure to thrive. Cataracts will be present bilaterally. Okay, and increased risk of Escherichia coli sepsis, and the children die because of this. Lab findings include increased bilirubin, AST and ALT, they will also be elevated. The glucose will be decreased. There will be metabolic acidosis because of the production of organic acids. Because of these galactose cannot be broken down, so metabolic acids like I don't know the name of that, but they start accumulating. I think it is galactitol or something, but I don't know. Then we have urine reducing substance will also be present in the urine. Diagnosis is may be identified on the newborn screening, and absent red blood cells GALT deficiency. Absent red blood cell GALT activity. Treatment is galactose-free diet, for example, soybean formula. ALT, alanine aminotransferase, aspartate aminotransferase, and galactose 1-phosphate uridyl transferase. Evaluation of the neonatal hydration. How do we do that? So firstly, we'll see for the signs of dehydration: decreased wet diapers, absence of tears, sunken fontanelle, dry mucous membranes, decreased skin turgor, and decreased capillary refill of more than 2 seconds indicates dehydration in children. Management of the weight loss. If the weight loss is less than 7%, continue exclusive breastfeeding. Follow up at age 10 to 14 days to check that infant has regained the birth weight or not, because they must regain it by the age 10 to 14 days. If it is more than 7 days, assess for oromotor dysfunction. What is that? Oromotor dysfunction. Assess for the lactation failure. Daily weights must be done, and consider the formula supplementation. Okay, just give me a second. So as per Google, the oromotor dysfunction is the oromotor refers to the group of disorders that predominantly affect the sensory input motor system, movement organization involved in sucking, chewing, swallowing, and speech articulation, and facial non-verbal communication. So this is oromotor dysfunction. as you can see here. So I'm sorry, my screen was not visible. So the term oromotor disorder refers to the group of the disorder that predominantly affect the sensory inputs, motor system and movement organization involved in sucking, chewing, swallowing, speech articulation and facial non-verbal communication. So now let's come back. So here you can see that the healthy infants lose up to 7% in the first 5 days of life, and they regain it by the 2 weeks, like 14 days. So this is peeling of the skin of hands and feet. This can happen in certain disorders. We'll see which ones. And dry, flaky, peeling skin is normal and is because of the adjustment to extrauterine environment. Uric acid crystals in the diaper. These ones normal in first week of life as mother milk is coming in. Then general rule: number of wet diapers should be equal to number of days in age in first week of life. So the rule is that the number of wet diapers should be equal to number of days in age in the first week of life. Like if it is like if the child is 3 years of age, 3 days of age, then the number of wet diapers should be 3. Then the next thing is about the plain water into infant less than 6 months should never be given because of the immature kidneys. They cannot reabsorb the water, which leads to dangerous hyponatremia and seizures because of dilution. There will be dilutional hyponatremia, and that dilutional hyponatremia can result into seizures. After that, we have overdose management. If the child is having iron overdose, prenatal vitamins have iron content and they appear as radio opaque tablets seen on abdominal x-rays. Okay, so that iron will be seen as radio opaque tablets on abdominal x-ray. Systemic manifestations will show abdominal pain, hematemesis, hypovolemic shock, and metabolic acidosis. How do we manage that? IV saline to treat hypovolemia and IV deferoxamine that binds to iron and that is then renally excreted. TCA and aspirin overdose. Tricyclic antidepressants? I think so. I don't think so. TCA and aspirin overdose. Okay, then in those situations we have to give sodium bicarbonate. Torsades they point this, we give magnesium sulfate is the treatment. Lithium toxicity. Hemodialysis is the treatment because it is most dialyzable toxin. For the lithium toxicity, we give hemodialysis because lithium is the most dialyzable toxin. And in the cases of lead poisoning, we use calcium EDTA in moderate to severe poisoning. Use oral succimer in mild to moderate lead poisoning. Remember this one as other are easy to remember. So like for lead poisoning, we give calcium EDTA and oral succimer. If it is very severe poisoning, then calcium EDTA, and if it is you know moderate lead poisoning, then we give oral succimer. For hyperkalemia, we give calcium gluconate. And then we have acetaminophen. We can give acetaminophen toxicity, use N-acetylcysteine. So acute iron poisoning, the clinical features are abdominal pain, hematemesis and diarrhea, shock, and liver necrosis. Diagnostic findings include anion gap metabolic acidosis, okay, elevated serum iron, radio opaque pills on the abdominal X-ray will be visualized. Treatment is deferoxamine and whole blood irrigation. Hematemesis melena, so bleeding is caused by the shock. Bleeding is causing the shock, tachycardia and hypotension. Okay. Then choking hazards in the children. Foods that are choking hazard should be avoided in age less than 4. A few examples of such foods are whole grape, raw vegetable, uncut hot dogs, hard candy, nuts, seeds, popcorns. While eating, make sure of following. Child is supervised, child is upright, and child is not running or playing. Now let's talk about allergy and immunology. We'll continue with the allergy and immunology in the next session. So until then, Allah Hafiz, Fi Amanillah, and take care.